Are you seeing my screen?
Yes, Mr. We are.
Okay, thank you very much. And thank you, Eric, for giving me the opportunity to talk to the young leaders of this group and to potential global experts and global surgical leaders in the different parts of the world. We know Africa as a continent might be trained from one region, but there is high possibility you could be trained, you could practice in another area and you can contribute to significant things that are going around global surgery and healthcare as a whole. So when I was approached by Eric to give this talk, it wasn't a surprise because we've been doing such activities for a while, and especially that now it has to come towards the lens of advocacy. And given my experience as a frontline provider, and also somebody who has been in the forefront of developing a national surgical plan, I know for sure it was meant to be at the right time. So for this presentation, this will be our outline. It's not as strict as it is. You can interrupt. We are going to add some more things to it, but this is what we're going to be looking at for these presentations. My journey, like Godwin has been saying, I started my practices as a clinical officer first in Sierra Leone, in rural Sierra Leone, where I saw the first-hand need of surgical care. And with that being said, I had the opportunity to have a 3-year post graduate training in general surgery and emergency obstetric, and I was instantly deployed in one of the remote setting. I had the opportunity and the privilege to work in the city, but I chooses to go where the need was much more than when you watch at our national data, where the need were much more, was a place I decided to start my practice as a surgical officer. And I happen to lead the association for over 4 years now. I tentatively suspend my leadership and come for the fellowship. And I've also contributed to the development of the National Surgical Plan, of which I had to give our lived and first-hand experience as a provider and also as a global surgery fellow who has been trained in that field. And currently, like you said, I am at the Center for Equity in Global Surgery as a fellow. Before I start with this talk, let me take you through a patient's story that I will not forget. The pictures might be awful, but this is a young guy who was around is 35 years of age, was working in the facility with us. He went on leave and had an injury back in his village, and his relative didn't show up with him in the hospital until we received him in this kind of state. It was a devastating moment for him and his family and the hospital because he was one of our dedicated porter who has been around and has been even seen us treating patients. Yet he could not make it to the hospital in time because of different reasons. We did manage this patient for quite some time, yet his relative at some point, either because of gap of knowledge, they had to take him to the village, and unfortunately we lose him after some period that is been in the village having traditional medication and all sort of things that we are beyond our control. But what is global surgery itself? Importantly, it's about the outcome and achieving health equity for all that needed surgical care, irrespective of the different definitions we have of seen about global surgeries. The most important thing is about us having an improved healthcare outcome for every patient that we see that needed surgical, obstetric, trauma, or anesthetic care. This is the most important thing we discuss around global surgery. It's all centered around the patient care and having a good outcome for this patient care. So rather from advocacy to the patient care itself, we deliver all encompasses global surgery, including the researches we do. It's all about giving a very good outcome to all patients, irrespective of their socioeconomic background that needed surgical, obstetric, trauma, or anesthetic care. Why is surgery matter? We know in the world today, evidence have shown that one-third of the disease burden requires surgical access. And we all are pushing for universal health coverage. And we know without surgical care, you cannot achieve universal health coverage. Hence, surgery is a core component of achieving universal health coverage. This makes it very, very much important. Also, we know that there is a huge crisis. Millions lack access. We used to estimate at 5 billion people lacking access to safe, affordable surgical care. We don't know what that number is as at 2026. The number we quote most of the time is around 2015. But I assure you, as at 2023 in Sierra Leone, 89% of our population lack access. We are not having surgery as they needed. That was the unmet need as at 2023 when we were collecting data for our national surgical plan. So it does mean that the crisis of global surgery is high. And how are we going to solve some of this problem? They have given us indicators that we can use to measure and see if we're making progress, which is access, the workforce, the volume, the perioperative mortality, and financial protection and catastrophic expenditure. The Lancet Commission of Global Surgery did outline this clearly and state that if we're able to create access through all of these things, then yes, it's possible for us to address this crisis we've talked about earlier on. I am very certain that some of these indicators have been mentioned by other speakers or will be continue to be mentioned by other speakers, especially when you continue to listen to talk around global surgery. But what is advocacy itself? I guess we all have been advocating in life. I bet you for almost everything we've achieved in life or we've been doing in our personal life, we've advocate. For one reason or the other, we just need that skill of advocate. So it's a strategic action to influence decision for policy or resource allocation. We have to be strategic when we talk about advocacy. We just can't come and say what we want to say. We have to be deliberate about it. So it's a strategic way of us giving information or talking about something in order to either influence decisions that are happening around policies or resource allocation. This will happen in everyday life of our clinical practices. You can advocate for patient safety, you can advocate for resources in your ward, you can advocate for resources in your department. At one point in time, we have advocated and we will continue to advocate for a lot of things that we need in order to solve surgical need or even in order to solve additional problems that are in the world, especially when it comes to healthcare. Why advocacy matters in global surgery? For far too long, our stories have been told by people, but it's become very difficult for people who have the money to spend. So we need to craft a way of sending in our message as global surgery professional to make surgery visible and in order to make it a priority. If you ask somebody who want to spend money, like Bill and Melinda Gates, for example, they would rather want to choose to spend that money on vaccination because the coverage is high. You see the prioritization, you see the visibility of it. But if we are able to tell our story, we are able to advocate for surgery, then we will be able to make it visible that it can be prioritized because it has a greater economic benefit. How has this advocacy evolved? Of course, there has been several advocacy that has been happening by organizations like Operation Smile, some of these short-term surgical missions, but a lot of this one has been fragmented. But in 2008, there was a paper written by Paul Farmer and Jim Kim. Jim Kim happened to be a one-time World Bank president. It's titled Voice Beyond the OR. And these people were not even surgeons. They were both internists. Yet they were able to see the need of surgery and they were able to start it because you have to talk about something. When you want to advocate for something, you have to get evidence. So they were able to publish this paper. And these were some of the papers that start to capture the attentions of people around global surgery. Earlier on, it was just global health, and it was difficult for you to have surgery into global health. Fast forward, the Lancet Commissions in 2015 had a whole technocrat who sat on things and come out with the Lancet Commission on Global Surgery 2015 to 2030 and set up these indicators that they were asking countries to monitor. Coincidentally, the World Health Assembly was also doing something around global surgery because by then there were some technocrats that who happened to be in the Geneva. So they were giving their input and they were able to pass a resolution that we all use today as a reference point, especially when we want to communicate with policymakers and our politicians, because it's a binding agreement. So the 6815 is one of the resolution you will hear about. And after the 6815, what happened? Countries started doing the national surgical plan, but it was quite on a low scale. And the NSUP movement also kicked into play. These are all advocacy strategy. Like I said earlier on, 6815 has been globally recognized because it's a binding agreement by all member states of the World Health Organization. So it's a binding agreement that we use today to do most of our advocacy, especially when we are talking to politicians. So in order for us as young professionals, where do we come in when we're really talking about advocacy? In the order I've presented it, it's not like this is a strict order. But in one way or the other, we have to come in from some point. In order for us to start advocating, we must have research. We must have researched the problem. We must have a data to an effect, and we must understand the patient's story and the economic analysis that are associated with this thing. Once you grab some of these things, any one of these, you do not need to be a researcher. You do not need to be an economist analyst. You can just collect your patient story and use your patient story to advocate for better outcome. Imagine you come to a facility where we used to have a facility, let me give this example, where all the laparotomy cases that were coming on the weekend, we technically will lose the majority of them because one they are coming in the weekend and we do like 100% out of pocket expenses. And we realize that then when they are coming in the weekend, they can't pay. And because they can't pay, the system technically delays the surgery until like Monday and we're losing them. But at some point, we realize that the few of us come together and like, at the end of the day, we are going to operate this patient. Why not we do the cases and they can pay later? And we were able to push that through our system, through our hospital policies, and we're able to influence those decisions. So it does mean that for us as young practitioners, at every point in time where we are, we just need the data, we need the patient story, we can give the economic analysis if we're able to do that, we can conduct a formal research to have this evidence, then we're able to make evidence advocacy that is going to be strategic. So for me as a frontline provider with my experience, there has been huge workforce shortage. Equipment is a problem, referral delays, and financial barriers. With all of these in mind, where do I come as a frontline provider? So when I am advocating or when I'm talking to you, I use a lived experience. For example, in Rwanda, we were looking at biomedical equipment because we realized that there's a huge problem of the equipment. So we were looking at it from a research point of view. Others are looking at workforce shortage. Others are looking at a facility. We all need this experience as frontline worker. We all need to be observant of our environment as to what is going on. Then we're able to position ourselves. What are we advocating for? What exactly do we want? But we, as frontline providers, need to be aware of our environment and categorize them into which categories to fall and see who can answer my question best. So, turning the experience into advocacy, like I said earlier on, we must be observant. We must able to ensure as a principle that we collect some amount of data. We can use a basic analysis. We can use it, even our notebook to just analyze evidence. Collect, for example, how many patients we have, what are the SSI rates we've gotten for the month. Is there any changes? You can use that to approach your leadership and see how those evidence you've generated can influence even institutional policy. It doesn't really mean it has to be at the bigger scale, but even at institutional level, we can definitely advocate for our patient. So in Sierra Leone, for example, we had a surgical tax shifting program. Some of you have heard about it, and some haven't heard about it. In 2012, there was a national survey that was done by an organization. Some of us were part of that organization. We realized by then that the country had less than 250 actively practicing doctors. We had majority some, but they were at ministry level, and we have a huge unmet need of surgery, which was around 92% as at then. And guess what? The majority of the surgical services were more in the urban setting. It does mean that people who are in the province cannot access cesarean section on time because there is no provider. So we had to push this agenda, present the evidence, and behold, the ministry was able to listen. And we started the surgical training program, which lasts for like 3 years in general surgery and emergency obstetric for clinical officers. So you see, it is with those evidence that we are definitely able to talk to the ministry that come look at the problem and look at what we're losing as a country. We need this kind of policy because at the end of the day, those people who are there do not have all the solutions. So when you are advocating, also, we're going to talk about that. You must also be thinking about what are the solutions. So that was how we were able to do our tax shifting program. And I assure you, as at 2026, we've graduated over 150 surgical provider, and we have a retention rate of like 90 to 95%, and 80% of those ones are posted in the rural district. So you see how the advocacy can make effect. Imagine how much they have contributed. In around 2012, our maternal mortality was around 884, and now it's around 354. So you see, in one way or the other, they have contributed to reducing maternal mortality and other surgical outcomes. Yet there are challenges even within those organizations we create or those institutions we try to build. There will be challenges with the coalition, evidence, and the engagement, and even the recognition. So what will happen? We collect data. We do not just train them, we collect data, we engage in advocacy at policy level, and we use some of these data to inform national decision. That even when you don't want us to have this training, but look at the data, what they are speaking. They are telling you that 70% of surgeries that are done, maternal related surgeries that are done by this clinical officer. Do you think somebody else is just going to crash those data and say, we stopped this program? No, so it all comes from a strong advocacy point of view that is backed by evidence. So as young professionals, we should be concerned about how do we do this advocacy? Should we not find sufficient information to do? And we can collaborate to do this so that at the end of the day, we have an impact on it. Like I was saying with the ENSOP movement, following all those resolutions, and we realized that even when you want to present those things to policy makers, that, a country, you have a bad data and you need to improve your surgical system. Yes, they wanted to improve it. But this is a new system, new in the sense they have not been discussing this. In most of the ministries of health, they've not been discussing it. So the technocrats in the global surgery sat together and realized, no, there should be a movement. There should be a team that will help country to develop this plan. Because if you want to discuss, if you want to talk to policymakers, you want to have change. Sometimes they are not resistance to change just because they want to do, but the fact that the technicalities of how do we even go around the national surgical plan, how do we improve the system? We don't know. Is it just go and buy equipment or employ more surgeons? No. So because there are a lot of things that are involved, as advocate, we must able to help them. So that is how the ENSOP movement came about, to help countries develop their national surgical plan and, if possible, help them with implementation roadmap. Currently, we have got a lot of African countries that have developed their ENSOP, but the challenge has been now with implementation. So through the Center for Equity in Global Surgery, now what has happened? We have a program that they've introduced where we are calling on DEX officers, we are calling on policymakers to come and attend that program. It's a 16-week program where they have a first-hand experience leading to us implementations because you just can't have the plan and give to the ministry. How are they going to implement it? So, in order for us to continue having the success we are seeing, we have to continue the advocacy at every level, understanding what that system needs and how can we help them best. So for Sierra Leone, for example, upon my completion with the Masters in Global Surgery, I went back to Sierra Leone to start working, and I was approached by the ministry that they've started the ENSOP in 2018. It didn't go far. We had the COVID-19, every other thing, and the kick of it in 2023, it was still stuck because they needed somebody who can guide the process. So in 2024 ending, they approached me and I took on the mantle, and behold, I was able to put a team together with other collaborators from not even within Sierra Leone that were helping with the process. At the end of the day, we were able to have our national surgical plan. And I assure you that because we have a frontline experience, we were able to ensure that we were speaking from a point where the patient is at the center of our decision. Whatever we are taking, it should be for the patient. So I called on you all that search for these opportunities. And if you are called to the table, it might not be paid job, but you have to because at the end of the day, you can't be given those opportunity to contribute to a document and you stay outside. Guess what? If you are not on around the table to discuss, you can literally be on the menu and being discussed as a menu. And none of us will want to be there. We do not want our patients to be there. So we want to discuss and have a good way of telling our patient story, give them informed data to inform our policies. So that was how we get in, through my advocacy, that was how we get in contact with the Sierra Leone NSOP and were able to help develop it. And like I said earlier on, every aspect of life you're going to advocate. In developing such policy document, everybody has their interest. Surgeons want their interest, the anesthetic want their interest, the other NGOs have want their interest. At the end of the day, you are able to navigate through these complex things in order to have consensus. Because even for you to have something on the document, it has to be with consensus. It's not going to be just your word. So a lot of advocacy is going to be there, meaning you're going to be strategic and see how do you present your idea? How do you present that, okay, we need to be sending the surgeons to the district hospital. How are you going to convince the board that, it's not just going to be in the city center. They need to go to the district hospital. But what are the mechanisms that are in place? You need to really have these things as you discuss with policymakers. So through advocacy, you can do your stakeholder mapping, engage with the different stakeholders. They could be governments, personnel, there could be clinicians, it could be patient themselves. Even patient themselves, we can advocate to patient because you have these delays. Some of these delays are technically as a result of their own problem. But if they really understand, we advocate with them that if you have a patient, come. And we solved one problem. We tell you, if you see a patient with similar problem, please refer them as early as possible. Even donors, we can advocate to them. Researchers, we can incorporate them. The media is telling the story the way they like. So until we are able to advocate them and come with them very close to us, then they are going to help us tell our story the way we want it to be told. So this will be like just a simple framework. In order for us to have a good advocacy, we must identify the problem, we must identify evidence, and we must identify which kind of message we want to send. You can't go to a policymaker that has given you a 5 minutes to talk and you want to explain all the problem. Find the message that you want to talk and who is the audience. Your message should be tailored to the audience. If you're talking to a politician, do you want to be using big terms? If you're talking to a practitioner, yes, you can use those terms. If you're talking to a policymaker, you tell them how this is important. So the framework is you identify your problem, the evidence supporting your problem, the message you want to send out, your audience, and you should always end up with what do you really want them to do? Because now we've developed the National Surgical Plan, we give to the ministry. What do we want them to do? in our messages, in our advocacy plan, we should be able to come up with what do we want Eric to do at the end of the day. If we're giving all of this to you guys here, what do we want you to do at the end of the day? So we must able to have a clear framework of how our advocacy looks like. Like I said earlier on, when we are communicating with policymakers, politicians, we must be very clear and give a clear recommendation that is feasible. We can't be recommending introduction of robotic surgery in Sierra Leone when we've still not addressed the number of open hernias that should be resolved with open surgeries. And we talked about robotic surgery. Is that a feasible solution? Or you talk about something that takes the entire national budget. Is that feasible? We have to be clear. The recommendations should be feasible at every time we communicate with policymakers. And sometimes we have to give the economy of surgery, present to them how important it is. For example, somebody who is riding a border has a family of two. If you give a story that if you lose that person, they have a fracture, they're going to stay home for 1 week, they are going to lose money, and the family will starve. It affects, by extension, affects the country as a whole. Then you have an economic argument, because most of the time, the economic argument is what we have not been able to present. And until we're able to show that if you have a surgery can save life and support the economic productivity, until we're able to give evidence and advocate for it in that economic matter, sometimes some people will not want to listen to you if you're just going to talk about how many number of fractures you fix. They are not interested in that, but they're interested in the economic productivity of it. And we definitely need resources. If you need the Ministry of Finance to talk to them about that, you want to advocate that they support the National Surgical Plan, you have to give them what is the investment on return. If they are going to invest, what are they getting in return? If you're not able to present those things, then your advocacy message is a little bit questioning, and you should refine it and get a clear message for them. The role of research. So, like we said earlier on, research is a very important component because it is one of the scientific ways that we use to generate evidence on workforce, on equipment, on the outcome and access. But most of the time, what has been happening around global surgery when we try to advocate, we only present the problem. We talked about the workforce challenge, the equipment, and the unmet need. But how about the outcome? Are we able to find the message? How many people do we have that have survived this kind of surgery that otherwise, if we had not come to this other part and provide this surgical care, they will have not gotten access to it? These are the kind of messages as well we should be able to communicate. Not all the time the negative part of it. Yes, the negative part have been there and people have researched a lot more. If you checked about access, there has been a lot more. Workforce, there's been a lot more. But how are we really telling the good stories? The positive outcome, not only the negative. Because sometimes the system themselves, the ministries of health we will be advocating, they also need a little bit of praise. So why not present the good part of things as well, that we've done this, done this, done this, and these are the outcomes which are very good. It does mean that if we continue to do X, Y, Z, this outcome will significantly increase. This is how we're going to be presenting our research. This is how we're going to be advocating for our patient. So research is a very fundamental component of global surgery advocacy. So we can also build coalitions. Eric is in Uganda. I'm in Rwanda now. I can be in Sierra Leone. I can see Professor Rice was on the call. He is in the state. A lot of other people can be, and we can build coalition. And it doesn't really mean that the coalition should always come from our subgroup. We need the media personnel. We need the patient themselves to even tell their stories. How many of us have in a meeting that we want to talk to patient and we come with one survival patient that come and tell them your story, how you came to the hospital, how we've helped you, and why should people come earlier, or why should people utilize the available resources good so that patient like you can survive again. We don't do that, but these are the things we should be able to do when we want to build our advocacy coalition. We think about people from different aspects of life and bring them on board. But yet, as we want to advocate, there are a lot of competing interests. And there's something called a policy window. The policy window is never, never opening all the time. There are times you want to really advocate about certain things, but the window is not ready yet. And for a policy window to align, you need to have a problem that is clear, and you need to have the policy that you have talked about. That's your like your advocacy message, and you need to have the politicians, because especially the politicians can come from different aspects. It can even be your leader in the hospital. It can be your boss in the institution. You also need those kind of people that, okay, this is something aligning with them. We can't have a national plan for 5 years that is talking about pediatric, it's not talking about surgery, let's say it's just talking about internal medicine and every other things. And all of a sudden, when the window has closed and you come in with your national surgical plan. So what we have realized in the past is that even the national surgical plan, we prepare it in alignment with the national health sector strategic plan, and we ensure that they have the same policy window, that they are within the time frame, because politics evolve. 4 or 5 years in Africa, you change. And some of these documents need to roll within that time. So we must observe what is the best policy window, and where do we want to when do we want to send this out. For example, I was doing something on petroleum. We wanted to tax petroleum so that we can finance our national surgical plan. I wanted to do an op-ed. I've gone very far with it. Coincidentally, the Iran American issue arises. The Strait of Hormuz was closed and fuel shoot up. That policy window was never friendly again for me to put any document out there. Otherwise, you could be caught in a different bad book, and they're still not going to listen to you because that wasn't the right time. And as we advocate, we want people to listen to us. So we must find the right time when we are going to give our message. And that right time is what in summary we refer to as the policy window, the window at which you know this message is going to have an effect. This could even be a problem. For example, if I'm advocating for safe ride for Boda Boda to have helmet in Uganda, you can find a problem. Is there a time where you have a lot of accident? And is it that these people could have survived if they had an element? And you can use that as a policy window to advocate to the border borders themselves that you guys need helmet in order to prevent some of these things. So we must find the problem, we align it, ensure that we have a clear message, which should be our policy, and the politician, that will be the leadership we're talking to. When those three things are together, are parallel, going in the same direction, then we say a policy window is open. And as at that time, you can have, if you have a strong message, then and a strong recommendations, chances are that they will listen to you. So what are the last lessons that I've learned so far? I've learned over the years that the stories of our patients are very, very important. The data we collect, if a patient data in a hospital, staff data, they are very, very important. The relationship we build with our leadership. In the Ministry of Health, for example, in Sierra Leone, I try to build a good relationship with my boss and every other one that are important, because the truth is, the leadership role evolves. If you are here today and somebody, because I'm only dealing with you as my boss, you are the only one that I'm concerned about. How about tomorrow if they remove you and come with Mr. Z? So the relationship will build, and how do we our presence, our presentations, and the leadership, the way we even carry ourselves around people will are very, very important in order that they will listen to you. If you are somebody who never cares about the patient, I know you from start, and we're working in the same facility, you never care about the patient. How can you talk to me about SSI that it's going up, or your credibility? It's difficult for me to really have that kind of credibility for you. So even the way we carry ourselves as leaders, it's very important. Becoming a global surgery advocate, I think one thing I would say is always try to collect data. I've talked a lot about data. Try as much as possible to involve in publication. This is very hard, but engage in publications, engage in mentorship like Eric is now hosting there, which are very good. by this, over a period of time, you are able to become a better advocate than the majority of us because now you start your career at a very early stage and you're able to see things and you're able to start talking about them. Even those in universities can still be advocate. You can still see things and be like, okay, we go to the community. We practice something in Uganda, in Rwanda called umuganda. These are things you can use during those sessions. Use the community impact week. We go and have discussions with people and help them. If they have a care that we think should be come to the hospital, or find a way through the center to help them get access. This is how we are going to advocate and help to provide solutions as our future leaders. So my key takeaway message is that advocacy drive policies change and a strong surgical system. The advocacy, it can drive significant policy change and a strong surgical system. Thank you very much for listening to me.